Welcome back. We will continue the bladder tumor. We will speak about the intravascular therapy for urothelial carcinoma. Intravascular therapy is indicated for stage TA, T1, TIS, urothelial carcinoma of the bladder. So this is indication for, or the tumor stage indicated or treated by intravascular therapy. Intravascular therapy is not effective for muscle invasive urothelial carcinoma stage T2, T3, T4, and non-urothelial tumors. There are two types of intravascular therapy, that's chemotherapy like mitomycin, tiotiba, and gemcitabine. This is the another is immune therapy, which is BCG, interferon, etc. There are three main indications for intravascular therapy are eradication of CIS or with or without associated papillary tumor. Eradication of residual papillary tumor after incomplete resection. To reduce recurrence and progression of a completely resected tumor. This is the three main indication. Eradication of CIS with or without associated papillary tumor. Eradication of residual papillary tumor after incomplete resection. To reduce the recurrence and progression of completely resected tumors. The term used to describe the timing of administration. Immediate postoperative dose on dose of intravascular chemotherapy administered within 24 hours. Ideally, this is within 6 hours after TURBT. The BCG should never be given intravascularly within 2 weeks of TURBT. It must be 3 to 4 weeks after TURBT. Induction course. Induction intravascular therapy is administered starting 3 to 4 weeks after TURBT. The first cycle typically consists of intravascular dose once per week for 6 weeks. This is the induction. The induction must be the first cycle typically consists of intravascular dose once per week for 6 weeks. The induction course should not exceed a 2-week cycle, the total of 12 doses. This is the 12 dose induction cycles. Okay, so we have 2 cycles of induction dose. It is a total of 12 doses. The 2-week 6 cycle. The maintenance therapy, intravascular therapy administered every several months after induction. Comparison of intravascular chemotherapy and BCG. BCG reduce tumor recurrence and progression. This is the BCG. Intravascular chemotherapy reduce all the recurrence. Example for this, mitomycin C. Intravascular chemotherapy reduce recurrence only, but does not alert the progression like BCG. An induction course of intravascular therapy achieve a similar decrease in the recurrence whether BCG or chemotherapy is used. This is the intravascular therapy achieve similar decrease of recurrence. Adding maintenance therapy with BCG reduce recurrence further. Okay, so adding the maintenance, this reduce the recurrence further. The maintenance therapy with chemotherapy does not appear to reduce recurrence when including all chemotherapy agents in the analysis. However, when analyzing each chemotherapy agent separately, maintenance therapy with mitomycin C may reduce the recurrence. So maintenance with mitomycin C, this reduces the recurrence. BCG is superior to the intravascular chemotherapy for treatment of CIS or high-grade tumors or stage T1 tumors. So this is superior to the intravascular chemotherapy. That's a BCG. So we'll use BCG in CIS, we'll use BCG in high-grade tumors, we will use BCG in stage T tumors, T1 tumor. one dose of intravesical chemotherapy may be used within 24 hours, ideally within 6 hours of TURBT in the absence of bladder perforation. BCG again should never be given intravesically within 2 weeks of TURBT. Side effects are greater with BCG than with intravesical chemotherapy. This is the difference between intravesical BCG and the no maintenance chemotherapy. Use single dose after TURBT. No, we will not use the intravesical after TURBT immediately. And maintenance, yes, here we will use 6 dose. We will use no maintenance chemotherapy single dose, yes. That's absolute reduction in recurrence rate is 14%. 6 to 12 week induction course reduce recurrence, yes, in both 6 to 12 weeks. Maintenance therapy reduce recurrence. In the intravesical, yes, reduce the recurrence, but the no maintenance chemotherapy is not reduce the recurrence, the maintenance. The maintenance therapy reduce progression. This is very important. Yes, it reduces intravesical, but not with BCG. Mean absolute reduction in progression, that is 5%, and for intravesical BCG. Side effect and toxicity, that's moderate to high with BCG and moderate to low with chemotherapy. This is the end of the lecture.